I'm Deb from Case Management. I'm the director. I have RNs and social workers who work for me. And there's two parts to our job. One part is discharge planning. So anything that you need to go home safely, or if it's to go to a facility, my case managers will work with your physician, with physical therapy to make sure that that gets set up. The other piece that we have is I have one RN that works directly with your insurance companies to make sure that they have everything they need to take care of your bill, because we don't want you to have to worry about that. So there's only a few things that I really need to kind of go over. And if you're going home and there's equipment that you need, we'll help obtain that for you. Every patient's discharge plan is different. So, and it's very difficult to know exactly what that's going to be before you have the surgery. So we've had patients come into the hospital and fully intend to either go to a rehab facility or go to a skilled nursing facility, but do so well, which is awesome, that they don't qualify, that they qualify to go home and perhaps have home health for physical therapy. Or we've had just the opposite. We've had patients come in fully intending to be able to go home, and the surgery, happened, and it's taking them just a little bit longer to get back up on their feet. And so in that case, we'll help reevaluate that plan. So how we do that is within 24 hours of your stay, generally, we come in and we do an assessment. So my case managers, my RNs or my social worker will come in and ask you questions about your home situation, who you live with, what equipment you already may have in your home, what services you may already have. If you have a home health, we'll ask the name, because we're going to help get that resumed when you go home. And any preferences, the most important thing to know is that we always take your preferences into account. So you will not have anything set up for you without us coming in and making sure that it's what you want, and in most cases having you sign that that's the choice you've made, because that's something that's required so that you don't have us setting something up that you actually don't want, or a company coming into your home that you actually prefer a different one. And as long as they can provide the services, then we'll set that one up for you. We take our direction from physical therapy as far as what you're able to do post-operatively. So if Todd says that you are, doing very well and can go home with home health, then we're going to come talk to you about going home with home health. If Todd's staff says that you need to go to a rehab facility, we're going to work on that for you. You do have to qualify. So the rehab facility will evaluate all the information that we have in your medical record after we get your permission to send it over, and then they'll see if you qualify to go to a rehab. There's also skilled nursings that offer rehab as well, and then of course home with home health or even outpatient therapy. All of those things could be part of your discharge plan. And again, it's very hard to predict before you come into the hospital. I know that sometimes you have a plan in mind, and then we'll reevaluate that plan. It's good for us to know that, but we reevaluate it after you have your surgery, once we see how you do. Are there any questions with any of that?
I think there was one question about when is home health set up?
Okay, we set it up while you're here, and they're supposed to visit you within 24 hours. That's the rule. So they come in to do your evaluation and get you all set up within 24 hours. Is that what the question was?
Yes, I won't be able, I didn't move early, I wouldn't be able to drive to here for outpatient.
Right, no, we can set up home health for you.
Oh, okay, so they can come and.
They'll come, they can do
exercise.
physical therapy, yes, exactly. Until you're able to get out and do outpatient, then, generally that is kind of how it goes. We do set up home health for you.
Until I'm ready to drive.
Until you're ready to drive.
Okay, thank you.
Any other questions?
Helps with the financial part. Okay, she's the one that comes up with, if you have a copay that you've got to pay and that kind of thing?
No.
Or is that somebody else?
That's somebody else. So what she does is she takes all of your clinical information and sends it to your insurance company and requests the authorization for your continued stay in the hospital.
Okay.
So you'll already have an authorization for your surgery. That happens before you come in. And then we'll request the authorization for your hospital stay following your surgery. So sometimes we already have it, and it's maybe an additional day. So like I said, every case is different. But within 24 hours of you being here, your insurance company will receive your clinical information following your surgery. A lot of things happen in that first 24 hours. Any other questions? All right. Well, good luck to you. We'll see you all when you come in.
Welcome to Resolute Hospital. If this is your first time here, we're excited to have you here. We look forward to treating you and taking care of you here in our facility. Kind of going to answer your question a little bit about the insurance and payments and things like that. If you haven't pre-registered yet, I would recommend that when we finish class, we go to the registration desk and do the pre-registration portion. That way you can look and see if you have any deductibles, any co-pays, or anything like that. Plus, if you pre-register, it's going to save you about 30 minutes off of your time the day of surgery. So you're going to have to come in that morning as well and go through registration, but it'll save you about 30 minutes of your time. They're not going to have to go through step by step of everything. So if you haven't pre-registered yet, if you haven't seen Ann or Angie, if you haven't done your lab work, your x-rays, anything of that nature, we'll need to get you pre-registered hopefully today if you can, okay? All right, moving on. So everybody's having a knee replacement. This is great. It's going to make it a lot easier today. We're going to go through all of our slides here. The book that you have in front of you is everything that's in the book is going to be on the slides. There's actually more information in the book than what we have on the slides. Again, if you have any questions, please feel free to ask questions. The questions that you ask will help us in the future, especially with the videos. What we're going to talk about in class is how to prepare for your surgery. Okay, we're going to talk about what to expect while you're in the hospital. Then we're going to talk about what to expect once you leave the hospital and then you start your outpatient or your home health or your rehab stays, okay? First thing we're going to talk about here is our patient safety goals. The first goal is improve accuracy of patient identification. So when you come into the hospital and you go through the registration process, you're going to get an armband. On that armband, you're going to have your name and your date of birth. We need you to check your armband, and we need to make sure that your name is spelled correctly, and we need to make sure your date of birth is correct. If your name is misspelled, or if the date of birth is off by 1 day or 1 year, that can have a huge impact on your ability to get medications, your ability to get your meals. It may delay some of your care. So when you go into registration, they're going to put an armband on you. They're going to ask you to check it. Make sure you double check it, okay? Make sure everything's spelled correctly on there. Make sure the date of birth is correct. When we come into your rooms, we're going to ask you your name and date of birth every time we come in. It's not that we don't know who you are. It's just we want to make sure we're in the correct room. There have been times where patients get moved in the middle of the night for some reason or another, and I walk into a room, whatever I have on my sheet of paper is not who's in the room. So that's why we always ask, doctors, nurses, therapists, case management will always ask, what's your name and date of birth, okay? So just to save you some time, when someone walks in, just go ahead and tell them who your name is and what your date of birth is. Second goal is improve effectiveness of communication amongst caregivers. Our shift change in the hospital is at 7 a.m. and at 7 p.m. every day. So our nurse is going to come in, new nurses come in, night nurses, day nurses will be going off shift at 7 a.m. or 7 p.m. What we are trying to start here in the hospital is to have a bedside report. That bedside report is when 2 nurses come into your room and they go over all of your information. How's the patient doing? How are they doing with their medications? Have they had a bowel movement? Have they been able to get up and go to the bathroom? Have they had a shower? All that kind of information those 2 nurses will be sharing with each other. If they do this, if they show up in your room, don't panic. This is actually a good thing. What research shows is when nurses or whoever's at your bedside and they're discussing your care, the patient becomes more actively involved in that care. When you're more actively involved in your care, you know what's going on, you get better results. So if you have 2 nurses show up in your room in the middle of the night or during the day and it's shift change time, don't panic, just feel free to join in. If they say something that you're not sure about, they said you took a medicine and you don't remember taking that medicine, at that point, feel free to interject. No, I didn't have that medicine, or yes, I did have that medicine, but it caused me to have these problems. Okay, we want you to be involved in your health care. My staff, before we come in to see you, we're going to go talk to your nurse. How's the patient doing? Have they had their pain meds? You want your pain meds before I come in. If not, you might not like me too much, all right? So we're going to make sure that you've had your pain meds before you come in. We're going to make sure that there's no problems from the night, no problems from the previous day or anything like that. So we're going to talk to your nurses before we come in to see you. After we finish treating you, we're going to go back and we're going to talk to your nurse. And we're going to tell them this patient's min assist, their mod assist. We're just letting them know how much assist they're going to need to give you in order to get you back to bed or maybe to get you to the bathroom, okay? At 9:30 every morning, from 9:30 to about 10:30, we have our hospital rounds. That's where our doctors, our nurses, our therapists, case management, dietary, respiratory therapy, they all come into one room. And we go over every patient, room by room by room. So we start in one area, we go over all the rooms, discuss each patient individually. Doctors want to know, is a patient on track for discharge? How are they doing? Is there any problems with therapy? Any problems with medications? Anything that they need to be aware of? And the same information is shared with the nurses and the other staff as well. So as you can see, we do a lot of talking about the patients before and during the day to make sure that you're taken care of. The third goal is improve safety in using medications. On your armband, you also have a barcode, okay? Your nurse is going to come in and they're going to scan your barcode. Once they scan that, all your information about your medication is going to pop up onto a computer screen. While he or she is in your room dispensing medicine into the little cups, they're going to be telling you what kind of medication you're taking. Again, research shows when you're involved in this process and you know what you're taking, you have a better understanding of your medications. One of the things that we want you to be aware of is side effects of medications, especially side effects of pain medicine, okay? If you don't know what you're taking and you don't know what side effects are going to happen, it could be kind of a scary situation. So if we put you on some new medicine and you've never had that medicine before, ask the nurse, what's this medicine for? Why am I taking it? What's it going to do to me? What should I be expecting every time I take this medicine, okay? We want you to be aware of what you're taking. Don't let us just give you pills because we can. Ask questions. We want you to be involved. Fourth goal is reduce harm associated with clinical alarm systems. If you've ever been in a hospital, you know that we have all kinds of alarms. We have bed alarms, we have foot pump alarms, we have IV alarms, we have fire alarms, you name it. If it has an alarm to it, it's going to go off. I don't want you to lay in your bed hour after hour after hour listening to IV pumps go off or some other kind of alarm going off in your room. If there's an alarm going off in your room, push your call light, okay? When you push your call light, what happens on the outside is there's a light that starts flashing. We have in our hospital what we call a no-pass zone. That no-pass zone means anybody that's walking by your room and the light's going off on the outside needs to stop and go answer your call light. Not everybody can help you. You may have housekeeping, you may have maintenance. The CEO might be up there, which he does come up there pretty frequently. Somebody may be walking by that can't help you, but they can go find someone that can. You may have a doctor, a nurse, a therapist, or someone else that can help you. That's good. They can come in, answer the call light, and get you taken care of. So don't be afraid to push your call light, okay? If you have an alarm going off, push your call light. The second thing that happens when you push your call light is we have what we call a little Vocera badge. When you push your call light, this badge goes off first to the nursing assistant. If the nursing assistant can't answer it, it's going to go to the nurse. If the nurse can't answer it, then it's going to go back down to the nursing assistant, and it's going to say you have an urgent call in room 350. And it keeps going off. You have an urgent call in 350. You have an urgent call in 350. If she can't answer it, then it goes back to the nurse. If the nurse can't answer it, then it goes to the charge nurse. Eventually it goes to the director of the floor. So somebody's going to know that you've pushed your call light at some point in time. So that's why we encourage patients to push their call light. We want to know if you need help. So don't be afraid to push your call light if you need something, all right? Fifth goal is reduce healthcare-associated infections. This is where I need your help. Anybody that's going to come into your room and is going to touch your knee must wash their hands. That includes me, your nurses, any physician that comes into your room, your surgeon, If they're going to touch your knee, they must wash their hands. Outside of every room, we have an alcohol foam dispenser. So some people may be doing this when they walk into the room, okay? If they don't do that, then we have on the outside or the inside of every room, we have an alcohol foam dispenser. So they may go over there and get a little squirt, put it on their hands, and wash their hands that way. We also have a sink in every room, okay? You do not want an infection. If you get an infection in your knee, the process is going to take a whole lot longer for you to recover. What could be about a 2-month process could extend to maybe a 6-month process, maybe a year-long process. I don't know. Depends on how bad the infection gets. So that's why I encourage patients, every time someone walks into your room, if they're going to touch your knee, please ask them, did you wash your hands? If someone gets upset, let me know, okay? But you don't want an infection, and the hospital doesn't want you to get an infection, okay? We also have what I call secret shoppers in the hospital. And those are people that are out and about on the floors, and we're watching staff wash their hands. So I'm one of them. Don't anybody tell anybody that I'm one of those secret people. But I watch people all day long, and I watch them walk into the room, I watch them walk out of the room to make sure that they've washed their hands. If they don't, we report it to our infection control nurse. Our infection control nurse reports it up to administration, and eventually it gets reported up to our corporate office. Okay, so somebody, if they're not washing their hands, they're going to get notified at some point in time, why were you not washing your hands? You need to start washing your hands on a regular basis. We do not want you to get an infection. We want to make sure our staff's doing what they are supposed to do to help take care of you. Okay?
Excuse me. Is that just basically for somebody touching the knee?
Mostly.
Not the food?
Not the food or anything like that. We still expect them to wash their hands, but I really want them to wash their hands if they're going to be touching the knee. Okay? We just can't take any chances on that. It's good to say our hospital, as far as I know at this point in time, we've had no infections in our hospital after a knee or hip replacement. And that's because people like you are asking others to wash their hands. All right? Even in the surgery, right before you go in for surgery, ask the surgery team, did you wash your hands? All right? I get reports every day from the surgery department. What are you teaching them? To wash your hands. All right? So we want them to wash their hands. All right, so why are we doing the joint replacement? Well, first thing is to alleviate your pain. Can't stand the pain anymore. You've told your surgeon over and over and over, you're tired of the pain. You've been to the office several times. You're tired of the pain. You can't take it. They probably have sent you to therapy before. They've probably done other things to help control your pain, and it just didn't get any better. So then they're also looking to restore lost function. That's where my group's going to come in. We're going to teach you how to get up and down from chairs. We're going to teach you how to get in and out of beds. We're going to teach you how to walk again. We're going to teach you how to get in and out of cars, things of that nature, okay? So you may have trouble right now trying to walk. You may have trouble trying to get into a chair. We're going to help you with those things. Good news is, the day of surgery, you get to start therapy that day. So as soon as your surgery's done, we give you about an hour or two, and then we're in the room after you get to the floor, and we start therapy that day, okay? The sooner we get you up, the better it is for you. The third one is to correct any deformity. That's going to be your surgeon's responsibility, okay? Your surgeons are all great surgeons. If there's any kind of deformities, any kind of bowed legs, if you got knock knee, something like that, they're going to get it straightened out for you as close as they can. They all do a wonderful job, and so they're going to take care of you on this portion. And then the fourth one is just to improve quality of life. If you've got grandkids you want to play with, great-grandkids you want to play with, if you like to go walking with your pet, whatever it may be, if you like to go shopping, if you like to be outside in the yard working, these are the things that we want to help you to be able to do, okay? It may not happen here in the hospital, but at some point in time down the road, we're going to teach you how to be able to do these things again, all right? All right, this section here, I'm not going to go into detail because I'm afraid it will interfere with what your surgeon's told you. I'll just tell you, please follow up with your surgeon, okay? So this is what a typical operating room looks like. Most of you won't ever get to see this because you probably will be asleep at some point in time before you get in there. But this is what your surgeons are going to wear. I typically call them a spacesuit, all right? You can see that they have the big helmets with the visors over their face. The top of the helmet usually has a tube that comes down to the back and hooks up to a power pack that helps circulate fresh air into the helmet. Helps keep them cool, helps keep the visors from fogging up, all right? They wear the big visors like that because what are they doing? They're cutting hammering, sawing, things of that nature to the knee. So they don't need anything that's splashing up into them and getting in interference with what they're trying to do. Everything that you see in the picture there that's blue is a sterile field. So anybody that's going to be up next to the operating table, any equipment that's up next to the operating table is going to be sterile. All right? Other than that, if it's not, then they stand off back in the corner or somewhere else. We have an air exchange in the room. Okay, I believe the air exchange is a constant air exchange. If you think about your homes, if you look out in a window and the sun's coming through the window, you may see dust particles floating in the house, right? In our operating room, because we have this constant air exchange, we're trying to keep those dust particles down to a bare minimum. Okay? We don't need something floating around in the air that's going to end up falling down into the surgical area. So that constant air exchange is to keep the air clean and purified for you. There's going to be a sterile preparation of your leg. Have y'all visited with Ann or Angie yet? You have, okay. So at some point in time, you're going to go to pre-admission testing to visit with Ann or Angie. And they're going to give you a bottle of what we call a HibaCleanse wash. Okay? They're also going to give you a book and tells you how to use a HibaCleanse wash. Follow those instructions exactly on the HibaCleanse wash. Okay? I believe the instructions are that you're going to wash yourself pretty much from the shoulder down. Okay? But you especially want to wash the area of the knee, whichever knee it is. Okay? You do that the night before, and then you do the HibaCleanse wash the morning of. Okay? You also have to make sure that you have clean sheets and clean clothes to wear the night before surgery. Okay? We want everything to be as clean as possible the night before surgery. The morning of surgery, again, you're going to put on clean clothes. Okay? So you're going to have to do a little extra laundry the night before or the day before. You put your clean clothes on, you come in for your procedure that morning. You're going to check in at the registration desk. Registration is going to get you taken care of. They take you up to the second floor, and they take you to the pre-op area. Once you get to the pre-op area, they're going to hook you up with the IV, okay? And then they're going to start to wash your leg again. This time it's going to be a little wipe, what we call a sage wipe or a chlorhexidine wipe. They're going to wipe it all the way down, usually from about the hip down to the toes. They're going to wash you again. Once that's done, you get ready to go to surgery. They take you back into the operating room. They're going to wash you again, but this time it's going to be with a betadine solution. The betadine solution may have a dye to it. It may be an orange or a blue dye. Okay, so when you wake up, if you have like an orange tint or a blue tint to your leg, don't panic. It's just that that's the dye that they've used for the betadine solution. Lets the surgeon know that your leg's been washed, okay, and cleaned. All right? You're going to be given 3 rounds of antibiotics. You're going to be given a round of antibiotic an hour before surgery. You're going to be given a round of antibiotic during surgery. And then you're going to be given a round of antibiotic either after surgery or the next morning. Okay? Once we've done the 3 antibiotics, we're typically done. We'll continue to watch your white blood cell count. We'll watch to see if that's going up. If there's any concern, your surgeon or your hospital doctor will order another round of antibiotics if needed. But normally we just do 3 and that's it, okay? The implants that we use, the first implants that get put in are going to be trial implants. They're kept here in the hospital. They go through a whole sterilization process required by the government. They go through a whole checkoff process before they're ever used again. So your surgeon's going to open you up. They're going to do the trial implants first. Put everything kind of back together. Test the stability of the knee. If they like what they've got in there, they'll take it all out, and then they're going to put in your permanent implants. The permanent implants will come from a vendor, okay? So whoever your surgeon uses, they all use somebody different. They're going to take those implants from the vendor, and then they're going to put them in, get you cleaned up, get everything sewed back up, and close your leg, okay? So sterile implants, we have the trials here. The permanent ones come from a vendor. They will either get shipped here overnight or they get brought in the morning of your surgery. Okay? Any questions on the surgical process? That's part of it. All right, here comes the bad part. Here's your test. You have an anatomy test after class. All right, this is your femur. Okay, this is your tibia, and this is your fibula bone. This is your kneecap or your patella, okay? The kneecap, the femur, and the tibia bone are usually what they're going to operate on, okay? We're going to kind of see some pictures of that here in just a second. This is a normal knee under x-ray, okay? This is what our knees should look like when we're young, okay? This is why we can squat. This is why we can walk, we can bend over, do the things that we need to do, and we don't have the pain. You can see that there's a nice, thick, black space between the two bones. That's one of the things that your surgeon's looking for when they do their x-rays every time. Okay, they're looking to see if that space is still good and to see if you've got enough space in there so that your bones aren't rubbing on each other. There's no nerve endings in cartilage, okay? But there are nerve endings in the bone. So when you start to squat like this and your knees are cracking and popping and all that, that's some of the pain that you're having, okay? Because those nerves are getting irritated, all right? So this is what a normal knee should look like. At the end, cartilage is not necessarily blue. They just highlight it blue here, okay? You have your meniscus here, okay? You have back here your ACL and your PCL ligaments, and then you have your other ligaments here on the side, all right? Cartilage is 6 times slicker than glass. That's why we can do this when we're nice and young. That's why this doesn't bother us when we're nice and young, all right? But here's what your knee probably looks like now. You can see on x-ray that space is gone. You have bone rubbing up on bone, okay? That meniscus has almost disappeared or worn out, okay? It's very thin now. You can see the cartilage has worn off, and it's worn off on the bottom here, so now when we bend, it's just everything's rubbing up on each other. That's causing your pain, all right? You can also see on the end of the bones here, you have some bone spurs, okay? The bones have kind of worn out, deteriorated, and it has started causing some bone spurring. So your surgeon's going to clean those off as well, all right? So this is what a typical implant looks like on most patients, okay? Some doctors will do different things, but this is a typical implant. You have the femoral part here that goes to the top part of the knee. You have your tibial base plate that's going to go down here, okay? So the femoral piece will come up here, and then the tibial piece will come down here, okay? And then you see we have the articular insert, which is a thick plastic piece. That's going to be your new meniscus, okay? I don't know what these are made out of. They used to be titanium. Everybody wants to know what they're made out of. I really don't know anymore. They change all the time. So I can tell you that down here and in here are tiny little beads. They're kind of impregnated onto the metal. So what's going to happen is your surgeon's going to do one of two things. They're going to do what we call a press fit or a glue fit. If they do a press fit, they're going to clean out just a little bit of the inside of the bone. And then they're going to hammer those pieces down into the bone. Over time, that bone and the material will grow up and secure itself onto those beads. Okay? If they do a glue fit, they're going to clean out a little bit more. They're going to pour glue down into the bones. Okay? It's not Gorilla Glue, it's a bone glue. Okay? They'll pour the glue down in there, they'll hammer the pieces down in there, the glue comes up, secures itself around the beads, they'll clean off the outer edges. Within 2 minutes, the glue hardens and the prosthesis is set. Okay? I don't know what your surgeon's going to do until I read the operation report. But they do one of the two things, okay? So this is what a typical incision is going to look like. It's going to go down the top part of your knee, okay? The length of the incision, I really don't know. It just depends on what the surgeon needs to do. The surgeon's going to make a cut on the top part of your knee, okay? It'll look just like this. The cut will look just like that. And then they'll take that top part and they'll hammer it on there or with either glue or with a press fit, okay? Then they're going to cut off a very thin layer on the top part of the tibia bone, all right? And then you can see they'll either do a glue fit or a press fit down into the top part of that bone. Then they're going to cut off a very thin layer off the back of your kneecap, all right? And they're going to put a plastic insert on the back part of your kneecap, okay? If you think about that second model that I gave you here, you can see that there's a lot of bone spurs on it, right? So if you think about the kneecap slides up and down as your knee bends. Well, if it's sliding up and down over these bone spurs, it's just causing irritation and changes to the back of that kneecap. So that's why they cut off a thin layer of that kneecap, and then they do a plastic insert on the back side of it, okay? So you'll have a metal piece down here. You'll have a metal piece on both sides of the bone up here, a new plastic insert down here, and then the back side of your kneecap will have a plastic part to it. And that's just to help everything move up and down smoothly, okay? This is what your knee's going to look like after surgery, all right? So every time you go to get an x-ray done, the implants are going to show up, okay? And so a lot of people want to know right here, well, am I going to set off x-ray machines when I go to the airport, or will I set off x-ray machines when I go to government buildings? Most likely you will, okay? Unfortunately, because of the times that we live in, if you go to the airport, you go to a government building, and you try to walk through one of their machines, and you set off the alarm, you're going to get the wand, and they're going to rub the wand all around you trying to figure out where the metal is, or they may pat you down. If they do, don't panic. You should get a card either from your surgeon's office or in the mail from the vendor that he uses for the new prosthetic parts. Carry that card with you at all times, okay? You're going to have to show the card every time you go through an x-ray machine. They don't care. They're still going to do the wand. They're still probably going to pat you down. But have that card with you just so that you can verify that you did have a prosthetic implant put into your knee, okay? You can see the little lines that are on here. These are just staples, okay? Some people want to know what those are. Those are just staples. Your surgeon's going to either use the staples to close up the incision, or they're going to use a glue to close up the incision, all right? If they do a glue, they're just going to put a glue right down the edges of the incision, and they'll put steri strips across it, and that will hold the incision together, okay? So not unusual to see that as well. I won't know if your surgeon's going to use staples or glue, again, until I see the operation report. All right, again, they all do something different. Once they're done, they're going to close your wound up in layers, okay? So they're going to start from the inside. They're going to start washing your incision out, okay? They're going to wash the inside of it out, get everything cleaned up as much as they can, make sure they haven't left anything in there, all right? Especially with them cutting on the bone, there may be little tiny bone fragments, so you're going to want to try to wash those out and clean that out as well, all right? Right before they close you up, they're going to inject what I call a cocktail of pain medication. Most of them are going to put it right there in the knee joint. That pain medication is going to last for about 24 to 36 hours. Sometimes we can get a little bit longer, all right? But expect for about 24 to 36 hours of probably not feeling much down in here in the knee, okay? You'll like that, but you won't like it when it starts to wear off. And we'll kind of talk about that here in just a minute, all right? Again, in 10 to 14 days, you'll go back to your surgeon's office. You'll do a follow-up visit with them. If you have the staples, they'll start to take the staples out at that time. When they take the staples out, they're going to put some glue right down the top part of your knee, and then they're going to put steri strips across that incision to help it stay closed a little bit longer, okay? If you already have the glue and you already have the steri strips on there, they're just going to make sure everything's staying in place like it should, okay? All right, controlling your pain. Everybody wants to know, how are you going to take care of my pain? That's a very good question. A long time ago, they used to use what we call the PCA pump. You probably remember, if you've ever been in a hospital and had an operation, you probably got a little device that you could push a button, okay? Or you probably have seen people where they could push the button. We don't do those anymore, okay? We don't give you the button where you can push and keep pushing, and you think you're getting medicine. You usually push it once, that's it. You have to wait a few minutes, 30 minutes usually, maybe longer, and then you get more medicine after that. Our surgeons very, very, very rarely use this, okay? If they use it, then something else is going on that they need to control your pain even more with. But very unusual for them to use this. So now most of them are using what we call the on-cue infusion pump. Your surgeons may have already talked to you about this if you're going to get one. What it is a big old ball full of medicine. It looks like a big old cue ball. It's full of pain relieving medication. It has a long catheter tip. That tip gets inserted into the thigh, okay? And that medicine just slowly drips onto what we call your femoral nerve. Now, because it's dripping onto the femoral nerve, that nerve controls pain, but it also controls muscles. So you have to be very careful if you have this, because when you get up and you try to take a step, your leg may want to buckle on you. So we ask that you do not get out of bed, you do not get out of the chair by yourself. If you need to get up and you have this on-cue infusion pump, you need to ask for help, okay? The last thing you need to be doing is get up and you take a step and that leg crumbles on you and you fall to the ground and you hit that knee. Because if you hit that knee and you bust that incision open, you're going right back to the operating room, okay? So if you have this on-cue infusion pump, again, it's a big old ball full of medicine. They put it inside a black bag, and then we put that black bag around your shoulder, around your neck, or we hang it around the walker or something like that. You'll know if you have it. Again, it has a long catheter tip, and they kind of tape it down where it sits inside the thigh here, okay? The good thing about this is the pain relieving medication is a constant drip. You can change the dosage that you get, but your surgeon will let you know how to change it, okay? So if it needs to be changed, your surgeon will tell you how to do that part of it. It acts fast, doesn't last very long, which is why you get the constant drip of medication, all right? Eventually, we're going to put you on oral medication. You have to be on oral medication before you go home, all right? We're not going to let you have the IV pump or IV or anything like that for pain medicine. The infusion pump, it may still be in your thigh when you go home because it has a little bit of medicine left. If that's the case, our nurses and the doctors will tell you how to manage that when you go home. Usually by that time, you're up moving around and you're doing pretty well. You have good muscle control. Therapy's been working with you consistently, and you're safe to go home at that point if it's still in the thigh. But we will let you know when you can start getting up and moving by yourself, okay? But the oral medication, you have to be taking some type of oral medication before you go home. We need to know that you're going to be able to respond well to it. You're not going to have any adverse side effects or anything of that nature, okay? So make sure we get you to that point before you leave the hospital. Oral medications take a lot longer to start working, 20 to 30 minutes maybe before they start working. But they last longer, which is why you can take them about every 4 to 6, maybe every 8 hours. Okay, so we're going to get you on that pretty quickly. If you're having problems with your pain, please call your nurse. Don't sit there and lay in pain all night long. We have plenty of nursing staff at nighttime. I had a patient one time, did not push his call light all night long. Waited till the morning. By that time, his pain was a 10 out of a 10 pain. And we were not able to do any therapy the whole next day. So if you need pain medicine in the middle of the night, if you need pain medicine during the day, call your nurse, all right? Some of the surgeons will allow us to do what we call breakthrough pain medicine. You get your narcotic, but they'll let us give you like a Tylenol or something like that to kind of get you over the hump till your next scheduled pain medicine, all right? So again, if you need help, you're having a lot of pain, let us know, all right? Let us know if you need help. This is a scale that you're going to see or people are going to talk to you about quite often while you're here. We're going to ask you pretty frequently, what's your pain? How's your pain level? Are you doing okay with your pain? If we ask you on a scale of 0 to 10 and you have a hard time answering the 0 to 10 scale, then we'll show you this face, the faces, okay? And then you just point to a face and then we kind of go from there. But 0 means no pain, 10's the very worst possible pain you've ever had. All right? I had a patient one time said they were a 10 out of 10 pain. but they were telling me jokes. And if you look at the picture, 10 out of 10 means they should be crying, okay? So if you don't understand it, we'll explain the pain scale to you, or we'll explain what it is, but you know where your pain level is, but we just want you to understand that if you say you're a 10 out of 10, then, I mean, it's painful. It's the worst pain you've ever had, all right? It's almost like taking a hammer and smashing your thumb with it over and over, okay? That hurts. If the nurse or therapist or the doctor walk in to your room and they ask you, how's your pain today? Don't lay still. Try to move your knee a little bit. Okay? If you lay still, you probably feel pretty good. But when you try to start moving your knees, that pain may start to increase a little bit. So when someone asks you how your pain is doing, I cannot speak today. When they ask you how your pain is doing, move your legs. Try to bend your knee a little bit. Okay? And that will give us a pretty good indication of where your pain level is. Side effects of pain medicine. People get worried about constipation, drowsiness, confusion, and addiction to pain meds. These are all very real possibilities. Okay? The narcotics that we put you on are strong dose narcotics. They can definitely cause constipation. If you have not had a bowel movement since you've been in the hospital, you need to let someone know pretty quickly. Okay? We need to make sure that you have a bowel movement before you leave the hospital. The last thing you need to do is go home, you have not had a bowel movement, and then you get sick, and then you have to come back to the hospital for constipation. So let your doctor know every time they come into the room. Let your nurse know every time they come into the room if you've had a bowel movement or not. All right? If you haven't had one, they're going to prescribe some medicine for you, or they may do some other things. I would suggest to you to make sure you drink plenty of water while you're in the hospital. Make sure you eat. Okay, get some food into your system to kind of help everything start working the way it should. It's not unusual for your bowels to stop working because narcotics will cause that. All right? Drowsiness, we'll be watching for this. If you're just totally sleepy, we can't keep you awake while we're doing therapy, then we'll talk to your nurse, we'll talk to your doctor and say, can we change medications or can we do something different? The patient's unable to stay awake. But that can happen. Drowsiness and confusion happen periodically, but not often. So we will be visiting with your doctor and letting them know. If you have a family member that comes with you or a friend that comes with you, and I suggest that you bring someone with you, they can help us watch for this because they're going to know you better than we will. And so if they say this is not who this person really is, then we need to start talking to the nurses and the physicians and make sure that we change medicines if we can. But we'll communicate with your surgeon before we change anything, okay? The last thing is addiction to pain medicines. We've all heard it in the media. We hear it in the news every day. You see something on TV or hear something on the radio about people getting addicted to narcotics or the opioids. This is a very real situation. What happens, and one of the things that happens, there's a lot of things that happen, but the biggest thing that happens is people don't take their pain medicine the right way. Your surgeon's going to prescribe you some pain medicine to take home. Take it the right way. Take it the way it's been written or the way the prescription's written on the bottle. One of the things that happens is people take a narcotic, it makes them feel really good. It relieves their pain, I've never felt this way before. I haven't felt this way in a long time. An hour later, their pain starts to creep up. Well, I like that feeling I had a while ago, so I'm going to take another narcotic. An hour later, they take another one. Man, I feel really good. Next thing they know, they're taking them every hour or every 2 hours instead of every 4 to 6 or 8 hours the way it's been prescribed. Next thing you know, they're addicted to the pain medicine. So I would tell you, take it the way it's been prescribed. Don't go any other way than what's on the bottle, okay? While you're here, we'll help you with that. We'll make sure that you take your medicines on a timely basis. You're going to be on what we call a scheduled narcotic or scheduled pain medicine. So every so often, your nurse is going to come in and say, it's time for your medicine. Do you need some pain medicine? They get a notification on their computer screen that says, this person it's time for their pain medicine. So they're going to be in 4, 6, or 8 hours, whatever the doctor's prescribed. Okay? Again, if you need your medicine, take it. If you don't, you want to try to wait a little bit longer, try to wait a little bit longer. but you'll know better than anybody else will if you need your medicine or not, okay? But I would suggest to you, stay on top of what you're taking. One of the things that my group found out recently was we kind of did our own little mini project here, and we asked all of our patients that we went to go see is, do you know what pain medicine you're taking? Do you know how often you're taking it? And do you know what the side effects of your pain medicine are? Almost all of our patients didn't know what pain medicine they were on, and they didn't know what the schedule was for their pain medicine. Once you get onto the floor, start asking your nurse, what is my pain medicine and when is it due? Write it down on a sheet of paper or have someone write it on the whiteboard that's in your room. That way you can see it every day. That way you know if you're taking it at 8 o'clock in the morning, 12 o'clock, and then the next time, you know that you can start calling for your pain medicine before therapy gets there. Because we want to make sure you have it before we see you. I don't want you throwing your shoes at me or hit me with a right hook or something like that. I want to make sure you have your medicine before we come in to see you. Okay?
How many times a day do you come in for therapy?
We come in twice a day. Good question. So how many times we come in today? In the day is twice a day. We go once in the morning and we come once in the afternoon. Okay? Our orthopedic patients are usually the first patients that we see in the morning and then the first patients we see in the afternoon, if we get a chance. Good question.
When does the doctor come in for rounds to check us, the surgeon?
So does the doctor come in for rounds to check on you? They do. They come at different times. Some of them will come early in the morning, probably around 7 or 8 o'clock in the morning. Some may come at noontime, and then some will come in after hours from when they're operating when they're at their clinic. So it's hard to say what time they'll be in there, but usually either first thing in the morning, right at the noontime, or sometime after 5. Okay? But they're all pretty consistent on that, so it's hard to say which ones are going to do which. But yes, sir. Good question. Caring for your wound. Again, it's going to be closed with staples or it's going to be closed with the what we call a dermabond or a skin glue. You're going to have a sterile dressing on top of your incision. The sterile dressing that they put on top of your incision is usually what we call an aquacell dressing. Most of the surgeons use this, some don't. If you have the aquacell dressing on top of your incision, it is water resistant, not waterproof, which means we can get you into the shower that night or the next morning, okay? So if you feel like you need a shower, ask your nurse. If your surgeon doesn't use an aquacell dressing and they just do a plain sterile dressing, which is like gauze pads and stuff, then we'll have to wrap your leg up before we get you into the shower. We'll wrap it up with a plastic bag, tape it down with a hospital-type tape, and then we'll make sure that the incision is covered before we put you in the shower, okay? The sterile dressing that is on your incision, we don't mess with it for at least 2 days. We don't touch it. Okay? We have found that when we leave it alone, it's better for infection control. Now, my staff, the nursing staff, the hospital doctors, anybody that's coming in the room to work to look at your knee or to work with your knee, we're going to inspect that dressing as much as we can. And if there's any kind of excessive drainage underneath that bandage, we'll call your surgeon and say, hey, is it okay for us to change the bandage, kind of filling up or not looking too good? Your surgeon will say yes or no. If they say yes, then the nursing staff's going to go get new bandages. They're going to come into the room and they're going to change your bandage out. Before they change your bandage, what do you need to ask them?
Wash your hands.
Did you wash your hands? Okay. They wash their hands, they change the bandage, they'll get you covered back up. If the surgeon says no, then they usually tell us, we're on our way up there to see the patient anyways, just leave it, we'll take care of it ourselves. Before the surgeon touches your bandage, wash your hands. Or you can just politely ask them, did you wash your hands? There's nothing wrong with you asking, did you wash your hands? Okay, there's nothing wrong with that, so don't be afraid to ask. The drainage that you may have should be kind of a clear straw color type drainage, okay? So we're going to be watching for that as well. If you have the aquacell dressing on there, again, we're going to leave it alone. The surgeon will probably change it out the day before you go home, and then they may leave it there until you come back to see them in about 10 to 14 days, which is just in time for you to take the staples out or to change the glue dressing, okay? We're going to watch for signs and symptoms of infections while you're here in the hospital, and then we're going to talk about signs and symptoms of infection here in just a minute. All right? And then we'll talk about how to care for your incision when you go home here in just a little bit as well. Any questions on this part? So again, the dressing that's going to be on there, if it's an Aquacel dressing, it's going to be a little bit longer than your incision. It's going to be kind of a dark brown edge, and then it's going to be kind of a light tan middle piece. All right? And we'll let you know. We'll look at it and we'll let you know if you have that or not. Okay? Actually, you won't. Dr. Jennings is your surgeon, so he does something different. He does a wound vac on the knee. So your incision will be closed. You'll have kind of like a little spongy type bandage on top of your incision, and then you'll have a plastic bandage on top of that that's hooked up to a little device that just kind of helps kind of suck out any moisture to help with the drainage and to help with the infection control as well. So yours will be a little bit different, all right? Anybody else go into Dr. Jennings? Okay. That's the only thing that's going to be different pretty much for you. All right, so how do we prevent complications? First thing is you get to wear these nice, pretty white stockings. Sorry guys, you get to wear them for at least 6 to 8 weeks, unless your surgeon tells you otherwise, okay? These are compression stockings. So they are very tight at the toes, all the way up to the thigh. Some surgeons may just do what we call a knee-high compression stocking, but these are called thigh-high compression stockings. You will wear these until your surgeon tells you otherwise. Okay? The band, the little stripes that you see right here, are little rubber bands that are on the inside of the compression stockings. They don't work very well. And so what happens as you're walking with therapy, you're working with therapy, you're getting up to go to the bathroom, whatever, those things start to slide down your leg. When they do, guess what happens? They bunch up right here. Well, if they're compressing right here, if they're compression stockings and they compress right here, you could slow your blood flow down in this portion of your leg. So all you need to do, if they are not pulled up and not smooth, then you just gently pull them up, stretch them out till they're nice and smooth from your hip all the way down. If you're not comfortable doing that, then just ask someone to help you. The nurses can do it, the therapists can do it. We can straighten them out for you, get them nice and smooth. But don't let them slide all the way down to the knee where they just sit there and compress hour after hour after hour. You could cause blood flow problems, okay? So make sure they're nice and smooth. Any questions?
So that's 6 to 8 weeks.
6 to 8 weeks that you may have to wear those. Your surgeon will tell you otherwise, okay? But on average, it's about 6 to 8 weeks. Now, you can buy extra stockings at most pharmacies around town. I'm kind of one of the crazy people that likes to go around town to the different pharmacy stores and see what's available. And I've been finding these in the different pharmacies. Walmart, CVS, Walgreens, they all have them, okay? You may have to ask where they're located. But if you need an extra pair of stockings, then someone may need to go to the pharmacy to get it for you. You hand wash these, okay? If they get dirty or you want to get them clean, you hand wash them in the sink, warm soap and water, and then they air dry. Do not put them in the wash machine or the dishwasher or anything like that. You'll ruin them completely, okay? Hand wash, air dry. The next thing that you will have on you is a little compression device. It won't be these exact ones, okay? But you'll have some little devices around your leg that are going to stay around your legs while you're here in the hospital. We hook them up to a little air pump device that sits at the foot of your bed. You may hear a psh sound. That's just because that's filling up with air and then it's releasing air. It's going to squeeze and relax. Squeeze and relax. It may vibrate a little bit and relax, but it's going to be doing different things to help with the blood flow down the lower portion of your legs. All right? The reason why we're doing the compression stockings in these devices is because this is where blood clots like to start. After your type of surgery, blood clots like to start down here. Okay, so that's why we're putting a lot of focus down here, is to help you prevent or help us prevent blood clots. All right? So you'll have these on when you wake up. You'll have these on every time you're in bed. The first day, you'll have them on when we put you in the chair. As you're able to get up and start moving better, we may not put them on as much, but we will have them on every time you go to bed for sure, okay? And then, like I said, the first day, if we get you up to a chair, you'll probably be wearing them as well. Some surgeons are sending a device like this home with their patient, and if that's the case, there will be a vendor that comes into your room, and they will go over the instructions of how to put the device on, how to hook it up, how to turn it on, how to turn it off. All right, but some of you may get this, some of you may not. It's very physician specific. All right? A lot of patients say they like them. They say it feels like they get a massage on their legs, so we'll see. All right, the next thing you're going to get is anticoagulation medication. All right? It may be an aspirin, it may be something else. Again, your surgeons all do different things, so we'll have to wait and see what they say. But you'll get a prescription. You'll take the prescription to the pharmacy when you go home, and you get it filled. Take all of this medicine. Do not skip any pills. Do not say, well, I'm feeling good. I'm moving around really well. I don't need to take my pill. You need to take all of this medicine until you go back to see the surgeon. When you go back to see the surgeon, they will tell you, keep taking it, or you don't have to take it anymore. Most likely you'll run out of it by the time you go back to see them. Okay? But you take all of this medicine until the surgeon tells you otherwise. Do not skip this one. Okay? This is the one that kind of helps thin your blood, again, to help prevent blood clots. While you're here in the hospital, you're going to probably get a shot in your belly. All right? The syringe is this long and the needle's this long. No, I'm just teasing. Actually, the syringe is about this long and the needle's about that long. Your nurse is going to walk in and he or she's going to say, I need to lift up your gown. I need to give you a shot in your belly. They're going to walk in and they're done. Okay, it's that quick. Most people tells me it feels like a little ant bite. So just a quick shot in the belly every morning, and that's again to help thin your blood, which is what we need to do after your surgery. Okay? And then once you go home, they'll convert you over to the pills. Next thing is get up and move. All right? We're going to come into your room right after surgery. We're going to come into your room twice a day, and we're going to get up and move. If you don't get up and move, you've wasted your time. You've wasted your money, and why even do this? Okay, again, we talked about the first 4 squares that we talked about at the beginning of the slides was you want to be able to restore function, return to some type of normal activity. This is part of it, getting up and moving. Okay? If you don't get up and move, you're going to stay in the hospital longer than you should. Guess what's in the hospital right now? Flu. The flu is really bad right now. You don't want to be in here and be at risk for catching the flu. So we've got to get you up and we've got to get you moving. The sooner we can get you up, hopefully the sooner we can get you out of here and get you to the next place that you're going to. All right? So again, we're going to be up we'll be here twice a day. We're going to get up and we're going to walk each time. We're going to try to get you walking in the hallways eventually. All right? Once we get you up and moving in the hallways, you're doing pretty good. Hopefully we get to discharge soon. Okay? All right. What's expected while you're here in the hospital? First thing is, bring some normal clothes. We want to get you in normal clothes as soon as we can. All right? So if you like to wear t-shirts and shorts at home, bring t-shirts and shorts. If you like to wear a nightgown, bring a nightgown, but this needs to be something loose fitting so that we can take a look at your knee. Okay? What I have found, this is unofficial research, but what I have found over the years when people are in hospital gowns, they don't feel good and they don't want to do anything. But when we put you in your normal clothes, you feel better. Okay? When you get dressed, you feel better. The other reason why I need you to bring normal clothes is my occupational therapist needs to work with you on how to get dressed and still protect your knee. We don't want you getting up and falling over and hurting yourself. So she's going to show you some devices that you can use or that you might be able to purchase to help you get dressed and get dressed safely.
How about shoes?
We'll talk about shoes in a minute, but yes, I do want you to bring shoes, shoes that cover the heel and cover the toes. So if you're going to bring some shoes with you, they need to be like regular shoes. No flip-flops, no sandals or anything like that. Okay. Tennis shoes, whatever you're wearing now works perfect. Okay. If you forget to bring shoes, don't panic. We'll put some socks on you. for sure, okay? Because we don't want you walking on the floor barefooted, all right? But something that's going to protect your feet for sure. Good question. What else? Questions on clothes. Socks and underwear, bring those. Again, my occupational therapist needs to teach you how to get dressed, how to get undressed, and still be safe with your new knees, okay? Second thing is perform your exercises. In the back of your book, on about page 30 or 31, is a list of exercises that you're going to do here in the hospital. I want you to be familiar with those exercises before you come into the hospital, okay? So if I walk into your room, if I'm your therapist and I walk into your room and I say, let's start your ankle pumps, you know that you've got to wiggle your feet up and down. If I say, let's do your quad sets, you know that you push the back of your knee down to try to get your knee straight. Okay, so I want you to be familiar with these exercises before you come to the hospital. We won't do all of them while you're here in the hospital, but you can do all of them while you're at home. My suggestion to you is to do 10 repetitions 3 times a day. Morning, sometime in the afternoon, and sometime before you go to bed. Okay? After your surgery, we'll do it completely different, but if you can get your legs strong before you come into the hospital, it'll make your recovery a lot easier. Okay? So, bring your book with you when you come to class or when you come in for your surgery. That way we can pull it out and we can go over all the instructions of the exercises. Underneath each picture is a description of how to do the exercise. So they're very simple, very basic exercises for you to do. Any questions on those? All right. The last thing that you see in the red is participate and do not refuse any treatment. I'll say this with a little bit of a caveat here. Don't refuse treatment, but ask questions. Why am I doing this exercise? Why do I need to get up and walk? What are we doing here? What's the purpose of therapy? Those are all very appropriate questions to ask your PT or your OT, whoever comes into your room. If I'm your therapist, you're not going to hurt my feelings if you ask those types of questions. I want you to be able to understand what's going on and why we do what we do. I do my exercises in a specific order, and then I explain that to you once we start your therapy, okay? So, don't refuse, but ask questions. The other thing is, this is an elected procedure. Nobody's making you do this surgery. The reason you're doing this is you can't stand the pain anymore, you're having difficulty walking, you're having difficulty doing the things that you want to do, and you can't stand it anymore. And so you and your surgeon have said, now's the time. So this is an elected procedure. Therefore, we've got to get up and we've got to exercise. We have to do it. You have to get up and move. Otherwise, like I said earlier, you've wasted your time, you've wasted your surgeon's time, you've wasted your money, insurance money, so why even do it? I think once you go through the whole process and you go through the whole recovery process, you will be glad eventually that you did do this surgery, okay? Now, people are going to ask the question, well, what if I'm nauseated? What if I'm sick and throwing up and I can't do therapy? Not a problem. I'll take care of you. I'm going to treat you like I treat my own kids. I'm going to go to a wash rag, I'm going to get it nice and cool, and as you're throwing up, I'll hold the bucket or the bag for you, and I'm going to get you cleaned up, okay? And once you're done, I'll clean you up. I may rub your shoulders for you, may pat you on the back a little bit, and when you're done, I'm going to go get your nurse. I'm going to tell your nurse, hey, your patient's been throwing up, can we get some medicine? He or she will come in, they'll get you some medicine, and guess what? I'll be back in 30 minutes, okay? Just because you're nauseated doesn't mean we get to skip therapy that day. Well, what if I'm sleepy and I didn't sleep well last night? Perfect. Let's do your exercises. Let's get you really tired so that when I put you in the chair, you can fall asleep in the chair. Or if you're already in the chair, we can get you back to bed and you can fall asleep in the bed, okay? You're not going to get a whole lot of sleep in the hospital because people are going to be in and out of the rooms, taking all kinds of things for you, doing things for you. So you will be tired. It's going to be hard to sleep. I promise you that. But that doesn't mean we get to skip therapy. Okay? So I sound like it's mean. I sound like we're going to be mean to you. We're not. We're going to work with you. But you've got to do your therapy. Okay? Your surgeon's not going to be happy if you don't do it. And then I've got to come in and convince you to work with your therapist to make sure that we get the results that you want. If you want to get the good results, you've got to work with your therapy every day. All right, so here's some equipment that you may need. I do not want anybody to buy a leg lifter, okay? I want your legs to be strong enough where you can lift your leg up and down by yourself and get it in and out of the bed by yourself, or to be able to lift it up to get into the car by yourself, okay? If you struggle with that, then we have some things that we'll do here that can help you. But otherwise, don't buy a leg lifter. Most of you do not need a sock aid, okay? The sock aid is for our patients that have hip replacements. So my occupational therapist is going to work with you on being able to bend over, get your socks and shoes on, okay? So you don't need anything like that. You might need a reacher, okay? You can buy a reacher, Walgreens, CVS, Walmart, Amazon. Actually, Lowe's has them, Home Depot has them, you name it. Most people are going to have a reacher. The reason why we want you to have a reacher is we don't want you bending over trying to pick stuff up off the floor. We don't want you reaching up trying to get something tall out of a tall shelf, because we don't want you to lose your balance and fall and hurt yourself. Okay, so you may need a reacher unless you have someone that's going to be at home with you all day, every day. All right? A walker. If you don't have a walker, my department will loan you a walker while you're here, and then our case management people will help you get a walker before you go home. Okay? We'll verify that your insurance covers it before we get it to you. If you already have a walker, I would suggest that you bring it in with you. Not the day of surgery, probably bring it the day after surgery, because my staff or I need to inspect it to make sure it's in good working order. I had a patient one time that said, well, can I bring my own walker? Yes, you can. He brought his walker in, it was all rusted out. He'd been sitting outside in the rain all day, all for months and months. So I didn't want him walking on it where it would break on him and then he falls and hurt himself. Can I get the four-wheeled walker? That's a question that gets asked a lot. I don't particularly like the four-wheeled walkers, especially after a knee replacement surgery, because they can kind of get out of control on patients. And if you forget to squeeze your brakes and you're trying to turn, that walker may go this way and you may go this way. So I'd rather put you either on a two-wheeled walker or just what we call a standard walker that has no wheels. The two-wheel walkers are kind of nice because all you have to do is just push them straight, but they don't go as fast as the four-wheeled walkers, okay? So if you have a walker, bring it in, let us inspect it, probably the second day. If you're going to need a walker, let Patrick know, he's our other PT. Let one of us know so that when we talk to case management, we'll let the case management ladies know we're going to need a walker, okay? The other piece of equipment that's not on here is people want to know, can I get a shower chair? Insurance does not pay for a shower chair. Insurance says it's not necessary for you to take a shower. Doesn't make sense when I've been telling you to keep your knee clean and for people to wash their hands, right? But insurance does not pay for a shower chair or a shower bench. What insurance will pay for is what we call a 3-in-1 chair or a bedside commode. A bedside commode sits beside your bed at nighttime. If you need to go to the bathroom, it's just right there. You don't have to worry about walking across the room to get into the bathroom. That bedside commode has a bucket. You can take the bucket out, put the chair inside the shower, close the lid, and just sit on that and use it as a shower chair. Or you can use it as an elevated commode seat where you extend the legs, put it on top of the commode. Now you have handles where you can help yourself get up and down off of the commode, okay? So we call it a 3-in-1 chair. Insurance will pay for a 3-in-1 chair, but they won't pay for a shower bench or a shower chair. So that's kind of how we get around that to help you out if you need one. So we're going to ask you if you need that type of equipment as well. And so we'll work with you. Our case management ladies will work with you, work with your insurance before we give anything to you, okay? If we give you the equipment here, then we just put it on the hospital bill and it gets taken care of that way. This is your only precaution. If you were having a hip replacement, you would have more, but this is your only precaution. No twisting, okay? Now this is going to depend on how long your surgeon tells you, all right? And what I mean is if I'm walking this way and someone's behind me and they yell out my name, I don't want to turn around and do this. Because what's happened when I do that, if I turn around like this, my toes are this way, my knees this way, my hips are this way, my shoulders here, and all I've done is I've taken this new knee and this new plastic insert that we talked about, and I've taken it and I've just grinded it down. Okay? We don't want to do that. What we want to do is someone yells out your name, they're behind you, just hold up your hand and tell them to come up to you. Or you can tell them, wait just a second, and then you turn small steps until you turn all the way around to face them. Okay, but we don't want any twisting on that knee. You're going to cause damage to the new knee, and your surgeon's not going to be happy with you. Okay, so be very careful with twisting. Your surgeon will tell you when you don't have to worry about that anymore. One of the questions I get is, can I go dancing again? You sure can. Just work with your outpatient therapist, your home health therapist, work with your surgeon. They'll let you know when you can go dancing again. Well, can I go play golf? If you like to play golf, yes, you can go at some point in time when your surgeon tells you it's okay. All right? We'll talk about other activities that you can and can't do here in just a little bit, but you're going to need to work with your outpatient therapist, your home health therapist, your surgeon on when to start doing certain activities. Okay? Controlling your pain. We talked about this a little bit, hit some of the highlights of the pain a while ago. Again, I'm going to tell you, take your pain medicine the way it's been prescribed. Okay? Don't do anything drastically different. Now, you can overlap pain medicine by about a 5 to 10 minute margin. What does that mean? Well, if you take your pain medicine at 12 o'clock every day at noontime, about 11:50 or 11:55, you can take the next dosage so that as the first one's wearing off, the next one starts working and you have a little bit of an overlap. The problem with that, if you do that and you have no clue what's going on in the world, your family says, you're out of it, you don't know what's going on, we can't get you to wake up, then you overlap by 5 minutes. If you still have no clue what's going on, you still can't function properly, your family says things are not right with you, then you can't overlap medicine at all. You're going to have to take it right when it's due every time. And you may get a little bit of a pain there, but it will go away once that pain medicine starts working. Do not overlap more than 10 minutes. And you need to be very, very careful if you do overlap. You need to pay attention to what's going on with your body. Your family needs to pay attention with what's going on with you if you're going to overlap by anywhere from 5 to 10 minutes. Be very, very careful if you do that, okay? Otherwise, just take it when it's due every time. One of the questions I get is, when do I stop taking pain medicine? I don't know. Whenever you feel like you don't need it, okay? We all heal differently. We all heal at different time periods, okay? You might be able to start spreading it out in 2 weeks to whatever time frame you need it. If you're taking it every 6 hours, you may be like, well, you know, today I'm going to try to go every 7 hours and take my pain medicine. That's okay. But at that 7-hour mark, if you're hurting really bad, then you probably need to stay at the every 4 to 6 hours that they've been prescribed. If you're like, hey, I feel pretty good after 7 hours, I'm going to try to go another hour, and you feel pretty good, okay, then keep spreading it out that way. I can't tell you when to stop taking medicine. I can't tell you when to take it. All I can tell you is take it the way it's prescribed, okay? Work with your physician, work with your outpatient therapist, work with your home health nurse if you have one. Communicate with someone about your pain medicine if you want to know when to stop taking it or how long to take it, things of that nature, okay? But by all means and purposes and so forth, take it the way it's prescribed, okay? Any questions about pain medicine? Again, we talked about side effects of pain medicine, one of them being constipation. Eat lots of fiber, drink lots of water. I'm going to give a little bit of a plug to our cafeteria here. We have very, very good food here. Our hospital food is not like typical hospital food, and the menu's not like a typical hospital menu where everybody, or old days where everybody got one meal all at the same time. Our hospital is, we go by a restaurant-style menu. We're going to give you a menu when you get admitted, and then you call down whenever you're hungry. Okay, so you want an ice cream at 3 o'clock in the afternoon, you call the cafeteria, you order an ice cream, they bring it up to you. If you want a certain type of meal, you just open up the menu, you call down, and you tell the person answer on the other end of the phone, I would like to eat the chicken schnitzel and mashed potatoes and whatever it is. And they will tell you, yes, you can have that, and we will get that to you within the next 30 to 45 minutes. Or if you're on a special diet, they will tell you you're on a cardiac diet or you're on a diabetic diet, so these are the things you can choose from. Okay, but you call down to our cafeteria anytime you're ready to eat. If you don't call, then they'll start to call you. Typically happens when I'm in there doing therapy. And so we have to stop therapy so you can order your meal. But sometimes they'll call back later. We tell them, hey, we're in therapy, call back. But if you haven't called by a certain time period, the cafeteria people will start to call you and say, hey, we noticed you haven't eaten yet. You haven't ordered anything yet. What would you like? Okay. And then they will work with you over the phone to get the right foods for you, make sure that you're eating every day. 9 o'clock in the morning, you want a Coke? Call down there. Hey, can I get a soda pop? And they'll bring it up to you, okay? The food here is very good. Our chef does a great job with his meals. The director has a great staff down there, so I think you'll be pleasantly surprised. If you don't want to eat the hospital food, and you want somebody to bring you something from the outside, you need to check with your nurse first to make sure it's okay. When we do have a lot of restaurants around the hospital here, so just make sure whoever goes to get you food, when they bring it in, make sure the nurse knows so that you know, or that we know what you're eating and that it's okay for you to eat it, all right? Drink plenty of water to help reduce the constipation. If you need somebody to fill up your water cup, we give you a big water cup. And just call for help if you need someone to fill it up for you, all right? Nausea, if you are nauseated, eat. If you don't like the food, we can get you crackers, okay? We can do something for you. If you're on a special diet, let us know. Some people are on the gluten-free diets, okay? I'm not, but if someone may say, well, what if I'm on a gluten-free diet? Let us know so that we can tell our chef and they can make special arrangements for you. Okay, sometimes that happens. But don't just let us keep giving you medicine on an empty stomach. Lots of medicine on an empty stomach can make you extremely nauseated. And then we're just going to spend a lot of time trying to keep you unnauseated if we can. So eat. It's good food. I promise you it is. All right, remember, we're going to ask you a lot about your pain. Let us know. Let them know at the night time, whenever you need, call for help, okay? Don't try to deal through the pain by yourself. How do I care for my wound? Again, we want to keep your incision clean. We want to keep it dry and intact, all right? No bathtubs, no swim pools, no saunas, no hot tubs. No, you cannot go floating down the rivers or anything like that until your incision is completely closed, all right? You can take a shower. If you get the Aquacell dressing, you can take a shower, but you cannot get into a bathtub. Now, when you're in the shower, if you're sitting on a chair and you have a handheld wand, which I would suggest you get a handheld wand for your shower, get your body wet, put soap around your incision, rinse it off, and then focus on the rest of your body. But don't let water just sit there and hit on top of that incision or those bandages. Remember, if they put the Aquacell dressing on, it's water resistant, not waterproof, okay? If the water sits there and hits on it, that bandage is going to slowly start coming off, and then we've got to work on doing something else for you, okay? No lotions, no ointments, no creams on the incision until it's closed. Well, my best friend says if I put this ointment on here, it's going to feel really good. It might, but not until your incision is closed. You don't need any kind of ointment or lotion or cream seeping down into that incision and causing an infection. Remember, if you get an infection, what should be a short time period may go longer, all right? So nothing goes on that incision unless it's been prescribed by your physician, okay? Well, what about vitamin E oil? I hear that makes the scar heal up really well. After the incision's closed. How do I know if my incision's closed? Remember, in 2 weeks after your surgery, you're going to go back to your surgeon. They're going to take staples out if they do staples, or they're going to change the dressing from the glue. At that point in time, they're going to put another glue and steri-strips across that incision now, and that's going to be on there for usually about 2 weeks. In about 2 weeks, those steri-strips are going to start to curl up on the ends, and they're going to fall off. When those steri-strips fall off after the 4th week, that's usually a good indication your incision is closed. But you'll need to communicate with your surgeon. They'll let you know, hey, it's closed, everything's looking good, you can start doing these things now, okay? But until you hear your surgeon say those things, no lotions, no ointments, no creams on that incision, unless your surgeon says it's okay, all right? Do not let anybody touch your incision. There's no need to pull off the bandages and show people on Facebook. We don't need that. I had a lady that wanted to show her hip incision on Facebook. No, I don't want to look at it. Nobody else on Facebook wants to look at it. So don't put it on there. Don't put it on Twitter or all those other things. Nobody needs to see it. Leave it alone. If you're going to hear anything, leave the incision alone. Don't pick at it. Don't scratch it. Don't rub it. You don't need to do anything to it. Okay? Your home health therapist, your outpatient therapist, your rehab therapist, home health nurses, rehab nurses, whoever's working with you, they're going to watch your incision for you. And they're going to make sure that everything's okay with your incision. If it's not, they're going to let the surgeon know, they're going to let somebody know, and get it taken care of. Otherwise, leave the bandages on there, leave it alone. Don't mess with it, okay? Leave the incision alone. If your home health nurse, home health therapist, rehab therapist, rehab nurse, if they need to change bandages for any reason, wash your hands. Tell them to wash their hands, okay? Until that incision is completely closed, people need to wash their hands every time they touch the incision, okay? How do you know if your incision is getting infected? A persistent fever of 101 or higher, and that fever doesn't go away. Lots of pain in that incision site, shaking, chills, anything like you would have anytime you have any other infection, okay? Increased redness, increased tenderness, increased swelling. You're going to have some swelling. It's going to be a little off color. You'll see a picture here in just a minute, okay? But it's red, it's irritated, it's on fire, it hurts. It hurts when you rest. It hurts when you do therapy. You've taken all your medicine, you get no relief. Might be infected, okay? Redness, streak marks up and down the leg, may be infected. If your bandages are off and you're starting to see a drainage, some kind of drainage come out of the incision, and it's a green color drainage, thick and green, might be infected. Don't call me. Don't call your primary care doctor. Your primary care doctor won't talk to you. They're going to say, call your surgeon. Call your surgeon immediately. They may prescribe more medication for you. They may ask you to come in. They open it up, clean it out, close it back up. They may ask you to come in, open you up, take all the hardware out, redo it. I don't know. It's just going to depend on what the surgeon thinks at that time. But if you start to have any kind of drainage and it's thick and green, you need to get somewhere immediately. Do not wait. Well, I can wait a couple more days. No, don't wait a couple more days. Get to your surgeon's office quickly. Call them and let them know. These are not made up pictures. I did not enhance colors or anything like this. This is a normal knee. This is an infected knee. Okay? Well, that doesn't look very good. That looks ugly. It does initially. It will look like that initially. Okay? It will be kind of bumpy like that. But over time, as the swelling goes away with the incision, that's going to smooth out, and you're going to have just a nice little line that goes up and down your leg, okay? This is what an infected knee does look like. It is red, it's irritated, it's miserable. If you've ever had like a infected finger or infected toe or something like that, that's how much it hurts, okay? Ingrown toenail, ingrown fingernail, something like that, causes a lot of pain. And that's how much pain you're going to be in with that. It's painful, okay? Again, you need to call your surgeon immediately. Get to their office as quickly as possible. Preventing blood clots. We talked about this a while ago. Wear your compression stockings. Wear them until your surgeon tells you otherwise. On average, 6 to 8 weeks, okay? Take your anticoagulation medicine. Finish the whole bottle. If you finish the bottle, he or she gives you another bottle, keep taking it until they tell you otherwise, okay? They will let you know when you need to stop taking your anticoagulation medicine. Get up and move. One of the questions I get is, how much do I need to move? Get up and move maybe once every hour at home. And once you get home, get up and walk around the house every now and then. Once an hour, once every 2 hours, okay? But don't just go home and sit and do nothing. You've done all your therapy and you just go home and sit and do nothing, then why even do it? You've got to get up and you've got to keep moving. You've got to keep yourself active. Please, thank goodness the holidays are over, please don't go shopping for 12 hours. I had one patient that went shopping. It was Christmas 4 years ago. She went shopping the whole day. Next thing I know, she's back in and her leg's nice, big, and swollen. Okay? So every now and then you need to get off of your feet and rest. Elevate your leg. Put some ice on it. That will help with the swelling. Okay? But just get up and move periodically around the house. Don't just go home and sit and be still. How do you know if you have a blood clot? Increased pain in the calf muscles, usually where it starts again. Okay? It's going to start down here and it's going to be very, very painful. I'm not talking a 10 out of 10 pain, I'm talking like a 20 out of a 10 pain. You try to get up and you try to put your foot down to take a step, and it hurts, okay? Someone comes in and they try to touch you on the leg down there, it hurts. They try to squeeze, it hurts, okay? It gets hot. You can kind of feel heat radiating off of the leg, okay? Lots of swelling, and it may just be swelling from the knee down. All right, the whole leg may swell even more, so that blood clot may be a little bit higher, okay? But it's tender, okay? Increased swelling, those types of things. Pain is constant. If you think you have a blood clot, call your doctor or come to the hospital. I don't care which hospital you go to, but get to a hospital immediately. The sooner you get in, the sooner we can take care of it and we can get this resolved, okay? If the blood clot breaks free and travels to your lungs, we've got a very serious situation at this point. You need to get either 911 to come pick you up, an ambulance to come pick you up, or you need to get to the nearest hospital immediately. You don't need to call anybody other than 911, to be honest with you. You need to get in, they need to get you taken care of. Well, how do I know if it's in my lungs? Sudden shortness of breath, uncontrolled coughing, difficulty breathing, all of these things. Chest pain, okay, they're listed in the book. If you think you have one, if you're not certain, then just go to the nearest hospital, okay? Now, this is where I usually start scaring people. I'm not trying to scare you away from your surgery. I just want you to be aware of the risks. These are risks that you have to be aware of before your surgery goes on. So don't let this scare you. We just want you to be aware. A patient last week almost walked out of class when I talked about this. Swelling. It's going to happen. On average, about a year for swelling. Maybe less, maybe a little bit more, but on average, we see swelling in the knees for about a year. Wear your compression stockings, take breaks, get off your feet, elevate your feet every now and then, put ice. If you're going to do ice directly on the skin, 20 minutes every hour. If you're going to put some kind of padding or towel underneath the ice, you can usually go about 30 minutes every hour. All right, but no more than that. But keep ice on there periodically to help with that swelling. Keep your feet elevated, take breaks. Walking, you're not going to have any limitations with walking. To be honest with you, if we can get you up here, we're going to try to get you walking about 150 feet while you're here in the hospital. So that's going to be out your room, about halfway down the hall, and back to your room. Okay? In about 2 weeks, you should be walking around the house or in the community with a walker, a cane, or nothing at all. Most of you will probably still be on a walker. Okay? In about 6 weeks, you should be out in the community with a cane or nothing. All right? As long as you do your therapy, you do what you're told to do by your surgeon and by your therapist, in about 6 weeks, you should be out in the community with no problems at all. Okay?
What about stairs and steps?
Perfect question. So what do you do about stairs and steps? If you have stairs or steps at home, we need to know, because we're going to practice those while you're here. You need to know how to go up and down stairs or steps before you go home, if you're going to go home. If you're going to go to a rehab facility or some other place when you leave here, we're going to try to cover it, but they're going to cover it even more. There's a right way to go up and down the steps, and we want to make sure you know how to do that. Okay? Very good question. But stairs at home in about 6 weeks, if you do them the right way, you should be able to go up and down them just hanging on to one handrail without any problem. Very good question. All right, squatting and bending. We're not going to teach you how to squat and bend here in the hospital. You don't need to know that early. The incision's still too fresh. We don't want to cause any problems with your incision. So people want to know, well, can I squat down and pick up the little dog off the floor? Can I squat down in the floor and play with someone, with the kids or something? You can eventually, but your home health or your outpatient therapist need to teach you how to do that. There's a right way to get in the floor, and there's a right way to get out of the floor, and those therapists are the ones that will teach you how to do those things, okay? So a lot of people want to know about this. You're just going to have to wait until they get you to that point. But early on, we don't touch it just because the incision's too fresh. Some other things to think about: overall energy and weakness. Remember, your body's still healing. You're still in some healing phases, even 4, 5, 6 months down the road. Your body's still healing. So there may be days that you don't feel like going to therapy. There may be days I can't do this anymore. Those are very real possibilities. Okay, it's kind of like the side effects of things. It's one of the things we want you to be aware of. Those are the days you need to go to therapy. Those are the days that we don't want you to skip therapy sessions. If it's home health, outpatient, whatever it may be, you need to go. That's when you're going to get the most benefit, because you're going to have to work really hard to get through that day, and you're going to see some good benefits from those days. Right now, your body has to work really hard to walk. Your body has to work really hard to get up and down from chairs because of the pain, everything that's going on. It's a struggle. We're going to take you from here, and we're going to bring you down to here. And we're going to slowly build you up to here with all your therapy. So don't panic. There's days that I just can't do it. I just don't feel like doing it. Make yourself fight through it and do it, okay? If for some reason or another you have to skip a therapy appointment, try to make it up during that week, okay? But try not to miss any appointments as you go through this. Factors that affect energy level, again, these are kind of some risk factors that you need to be aware of. There may be some weight changes, there may be some heart, lung health changes, there may be other medical concerns that start to pop up. We just want you to be aware of it. Doesn't happen to everybody, but we want you to be aware that these things can happen to you while you're going through your recovery process. Returning to work. If you're planning to return to some type of desk job, we ask you that you wait 4 to 6 weeks. If you're returning to any kind of manual labor, heavy lifting, or anything like that, we ask that you wait 6 to 8 weeks. Your surgeon will tell you, will give you clearance of when you can return to certain activities. So if you're planning on doing some type of work, let your surgeon know. That way they can clear you to return at the appropriate time. Maintaining exercise. This is a lifelong commitment. Okay, this is not, you're done with the hospital stay, you're done with your physician care, you're done with your outpatient therapy, you're done with your home health therapy, I'm done, I'm not doing anything else. Wrong. You have to keep exercising. There's plenty of gyms around town. There's a gym right across here. It's called HealthLink. I'm giving them a little bit of a plug right now. You can join them. They have great people over there that can help you with exercise equipment. And they can teach you how to use the equipment properly after you've had a knee replacement. If you want to go, if you live here in New Braunfels, there's the new fitness center downtown. Get with one of their trainers. They can help you on the equipment or show you different things in their facility, whatever it may be. But just because you're done with all this does not mean you're done. You have to keep exercising. You have to keep moving. You need to watch your body weight. You need to make sure you eat healthy and try to watch your body weight. Excessive weight on the new joint can cause it to wear out faster. One of the number one questions I get is, well, how long will this last? On average, 20 to 25 years is typically what we see. I can tell you we had a patient last year that came in about February of last year for what we call a revision. The revision is where they come in, they kind of replace some of the hardware. His first surgery was in 1970s. His second surgery or his first revision was in 2018. So he got more than 20 to 25 years out of it by doing what he was told to do. Take care of your knee, take care of your body weight, take care of your health, eat properly. You might be able to get a lot more time out of this new joint. But you got to work with your surgeon and work with your therapist and make sure you do the things that you're supposed to make sure it lasts longer for you, okay? I can't tell you specifically it's going to last 20 years. I can't tell you it's going to last 10 years. I don't know. It just depends on how well you take care of it, okay? But work with someone to make sure you take care of it properly. Role transitions, again, there may be days where you feel ill, you just feel blue. Again, these are kind of some risks. Don't try to deal with it by yourself. If you're just feeling depressed, anxiety, you just don't feel like doing anything at all, call your doctor. It could be related to the medicine. Okay, your surgeon may need to change some medicines on you. They may need to change the way they prescribed it. They may need to add something or take something away. So don't just sit at home feeling down, depressed, and blue. Call someone and ask for help. Again, that's why we tell you bring your family members with you, get them involved so that they know what's going on and they're aware of how you're dealing with this transition. You're going to go through a lot of transition period here. Have someone with you, have someone help you through this, but don't let yourself get to a point where you just can't do it anymore and you get depressed. Let the surgeon know they can do something for you, okay? All right, what do you need to bring to the hospital? Bring your shorts and shirts, okay? Nightgowns, whatever you need to wear, something comfortable, something loose fitting, so that when we come in to look at your incision or when we come to work out, that you are comfortable, okay? Again, I don't want you in a hospital gown, and especially I don't like walking people in the hospital gowns down the hallway and they're flapping back here, okay? So if we can get you in regular clothes, we want to get you in regular clothes as quickly as possible. Bring toothbrush, toothpaste, socks, underwear, all that stuff, okay? My occupational therapist needs to be able to work with you in the bathroom to make sure you can do all these types of activities in the bathroom safely and that you're not at a risk for a fall. The last thing you need to do is fall in the bathroom at home or here, and then we have to start all over again, okay? So bring those types of devices with you. Sneakers, closed-heeled and closed-toed shoes, no slip-ons, no flip-flops, no sandals or anything like that. If you have an iPhone or some kind of smartphone, if you have a tablet or something like that, you're more than welcome to bring those with you. We do have free Wi-Fi throughout the entire hospital. If you log on, in about 4 hours it's going to kick you off. It's just a security feature that our IT has. Don't panic, you can log back on. If you can't or if you have trouble, let somebody know. We can quickly get you logged on to our website or to our internet. Okay, but you're more than welcome to bring your smartphones or your tablets with you. In the rooms, we have TVs in every room, and we do have movie channels. So if you like to watch movies, we do have a movie channel that you can select all kinds of movies from. They're usually the most recent movies that have been out within the past 4 to 6 months, okay? Some of them are pretty good. All right, glasses and dental appliances. Bring those with you. But bring the containers with them that you put them in, if you have them, okay? Do not, please, 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 do not leave your dental appliances, your glasses on the food tray. I promise you they will get thrown away. We do not like to replace those. You do not like to repurchase those. They're too expensive for everybody. So my request to you is if you have dental appliances or if you have glasses and you need to take them out or whatever you need to do, put them in their container and set them off on the nightstand that's by your bed or set them off on the table, over the bed table, but do not leave them on the food tray. Staff come in, they pick up those trays, they carry them off. Dietary people come up, they get them, they take them down, and they just dump. They're not looking to see what's in there, okay? So we don't want to replace them, and you don't want to have to buy them. We want to work together as a team to make sure that you get what you need, but sometimes it gets ugly if people start to lose their glasses and dental appliances and things like that. So make sure you don't have any of that on the food tray. Cell phones, tablets, or anything like that. Do not leave any kind of expensive phone or tablet like that in the covers. My staff, sometimes nursing staff, we come in, we pick up all the covers, and we just go and we put it in the laundry basket. The laundry basket gets taken out daily. If your phone's in there and you don't remember and we don't see it, it just got thrown away. Again, we don't like to replace new phones, especially those new iPhones that are $1,000. Okay? And you don't want to have to buy another one. That's not fun either. Okay? So if you have anything that's expensive, keep it on the nightstand or keep it on the over-the-bed tray, but not on the food tray, not in the covers. All right? We don't want to replace anything, and we don't want you to have to rebuy something. Safety things around the house. If you have any loose throw rugs or any loose extension cords around the house, you need to pick those up and remove them for 6 weeks. Until you're up and walking around safely, we don't want you to catch your toe on the rug or a cord and trip and fall. So those need to be picked up and moved out of the way. If you have any small pets and you already have a walker, go ahead and get the walker out now and let the pets be comfortable with you on the walker. Small dogs will attack a walker, or they'll attack crutches, or they'll run between your legs while you're walking, and you may trip and fall. Again, the last thing you need to do is trip and fall, land on that knee, and then have to come back to the hospital. Okay? So get your pets familiar with the equipment that you're using. If you don't have any of it, when you go home, as soon as you get home, go sit in the couch. Make sure the dog or whoever's been put up out of the way until you get into a comfortable spot. And then let your pets out so that they can come see you because they probably miss you. But as you get up and start moving around, someone's going to need to hold that pet so that you don't get in trouble and they don't start running around. We don't want a dog to come up, hit you in the back of the leg, cause your leg to buckle, and then you fall over. Okay, so the pets are going to need to be controlled somehow or another until you're up moving around safely. Night lights. You need night lights in your house. Okay? The last thing you need to do is get up in the middle of the night and go to the bathroom, and on your way, you trip and fall. You remember the picture, the x-ray that I showed you, where the prosthesis came down here and then it sits up here? If you trip and fall in the middle of the night, guess what could happen? You break your leg right below that prosthesis. And I've seen it way too many times. In my 17 years of doing this, I've seen it too many times, where a patient gets up in the middle of the night to go to the bathroom, they trip and fall, and they break right below that prosthesis. Currently, most likely, you will be what we call weight bears tolerated after surgery, which means you can stand up on both feet and you can walk. But if you trip and fall and break your leg, most likely you're going to become non-weight bearing, and now you get to hop around on one leg. Okay? Put night lights in your house if you need them. If you can see, then do what you have to. But if you can't see to get up to go to the bathroom in the middle of the night, I would suggest you put one in your room and one in the bathroom. If you have to walk down a long hallway to get to the bathroom, then put a night light in the hallway. But do not get up and trip in the middle of the night. I don't want to see you back here with a broken leg. You can come back and visit, but don't come back with a broken leg. If you break it, don't do that. Again, no open-toed shoes, no slip-on shoes until you're up moving around safely. We want you to be safe before anything else happens. Sit in elevated chairs. Make sure I'm not forgetting something here. All right. Your hips, I'm going to move over here. Hopefully y'all can see me. Your hips need to be higher than your knees to get in and out of chairs. If your hips are below your knees and you try to get up, you're going to have a difficult time. You're going to have to push a lot harder with your arms and push a lot harder with your good leg to get up to a standing position. If your hips are higher, it's going to be a lot easier to get up and down. Okay? Well, I have this favorite chair that I like to sit in. I've had it for 20 years. It's comfortable. It fits me perfectly. But when you sit in it, you sink. Okay? If that's the case, and you can take the cushion out, put about a 1/4 inch of plywood underneath the cushion, put the cushion on top of the plywood, and see if you still sink. If you do, then put some pillows underneath you where you're propped up. Okay? But we do not want your hips lower than your knees, or you're going to have a difficult time getting in and out of chairs. All right? Don't sit in chairs with wheels. Unfortunately, this is all we have in here. If you sit in a chair with wheels and you go to back up and you accidentally hit it and you don't realize that you hit it and you go to sit and that chair's not there, you're going to fall. You could do some damage to your knee, okay? Or it's going to hurt really, really bad because your knee's going to go really fast. So make sure if you sit in a chair that has wheels, someone's holding it for you, or that you have a good hold of it before you go to sit and before you go to stand, okay? Otherwise, you're going to fall, and we don't want that to happen. Any items that you're going to use frequently, towels, socks, underwear, pants, whatever, dishes. If it's in a cabinet that's really high, it needs to come down to your shoulders. If it's in the cabinet that's really low, it needs to come up to mid-thigh. We only want you working in this area for the first 6 weeks. We don't want you to open your tiptoes. We don't want you bending over. We don't want you to lose your balance and fall. So all the stuff needs to come up or down, shoulder to mid-thigh level. Okay? Take your time getting out of a shower or a bathtub. Water's going to be an enemy for you. If you have tile or linoleum floors in your bathroom and you get up and you go to take a step and your feet are wet, the floor's wet, and you slip and fall, again, you could cause some damage. All right? So we want to make sure that you're completely dried off before you get out of the shower or the tub. We want to make sure the floor that you're going to be stepping on is dry as well. All right? Keep your walker close by. Some people like to put chairs outside the tub or the shower so that they can just go right over there, sit down, and completely dry off if they need to, and get dressed right there. But you got to be careful with water. Days like today, you're on a walker and you hit a puddle and you slip and you fall, could cause some problems to your new knee. All right. No heavy lifting for 3 months. So if you need someone to carry something for you, just ask them, can you carry this for me? Don't try to carry your tray or your plate from the counter over to the table. Let someone else carry it for you. You hang on to the walker as long as you need to, okay? Is this safe for me to do? If you can say yes, then proceed. If you can't say yes, if you don't feel safe with whatever activity you're doing, then don't do it. Get someone to help you with it, okay? Keep cell phones close by. If you're going to be home by yourself for an extended period of time, keep your cell phone charged. Keep it ready to go. Keep phone numbers close by in case you need to remember who to dial. All right? You need to be able to call someone for help if you're going to be home by yourself. You need to let a neighbor know, hey, can you come by and check on me? I'm going to be home by myself for a couple of hours till my spouse gets back or till a family member gets back. Can you just come by and check on me and make sure I'm okay? Nothing wrong with asking that question. We just need you to be safe if you're going to be home by yourself at any length of time. Cell phones need to be ready to work in case you need to call for emergency help. All right? Don't get stuck in the bathroom and your cell phone's in the kitchen. Take it with you wherever you go. Okay? If you're not feeling good, call for help. Call your surgeon. Let them know. Use a pill organizer. Okay? We may add some medicines to you. We may take some medicines away from you. You need to keep on top of your medication. Make sure you're taking the right things at the right time, that you take them every day as you're supposed to. Okay? We don't want you getting confused and, did I take 2 pain pills or did I take 1? Did I take 2 blood pressure medications or what did I take today? So you need to keep a pill organizer available so that you take the right medicines at the right time. If you have stairs, make sure your stairs are clean. Make sure there's no toys on them. If you have kids that come over to the house, but make sure you can go up and down the stairs safely, okay? The last thing you need to do is trip going up or trip coming down. Then you're going to have some big problems. Activities that you can participate in: low impact aerobics, bicycling, dancing, elliptical machines, treadmill, golf, light walking, okay? These are all safe to do. These are low impact activities on your new knee, okay? I do not want you doing football, basketball, baseball, hockey, or anything of that nature, water skiing. That's going to be heavy impact on the knee. Again, that's going to cause a wear and tear on that new prosthesis. Question I've had in the past is, well, can I go running? Talk to your surgeon. But most likely your surgeon's going to say no. I was in a class recently. Orthopedic surgeon had a patient that had a knee replacement. He was a marathon runner. And he asked if he could continue running marathons. The surgeon said no. The patient says, well, I got to. I'm a marathon runner. I can't quit. The surgeon said no. The patient went and ran a marathon, and he caused damage to that new insert. That plastic insert, he caused it to crater. And when he did, the surgeon had to come back in and replace that. And then the surgeon says, you're no longer my patient. You need to go somewhere else if you're not going to follow the instructions. So if you're going to do certain activities or certain activities you want to go start doing or return to, clarify it with your surgeon first to make sure, okay? You don't want to cause damage and then they have to redo the procedure. Expectations. Takes up to about a year, okay, approximately a year for pain elimination. Some people less, some people more. On average, it's about a year for pain elimination. Swelling will kind of come and go as well. So again, an average of about a year for swelling to come and go. In about 4 to 6 weeks, you're going to be feeling pretty good. You're going to be moving around really well. You're going to be glad that you did the surgery procedure. You're not done. You're still healing. Takes up to about a year for healing, okay? Maybe a little bit longer, but on average, it's about a year for healing. Pearls of wisdom. Always tell your dentist that you've had a joint replacement. Why? When the dentist or the dental hygienist go in to clean your teeth, that bacteria is up underneath your gum. If they stir that bacteria up, it's going to go to the place of least resistance. The place of least resistance is your new prosthesis. Some people come in with infections and we don't know why. We finally figure out, well, they went to the dentist, had their teeth cleaned. I would suggest that you talk to your dentist before you go to see them. My dentist does not believe in giving antibiotics before the dental cleaning if people have had surgery. But there are others out there, there are other dentists out there that do believe that. So you need to visit with your dentist before you go in with any kind of dental work to be done. You might want to let your surgeon know, hey, is it okay for me to go get dental work done yet or do I need to wait? But you need to let both of them know, okay? Because you don't want to get a potential infection. All right, my dentist does not believe it. But I know of other dentists that do believe that you need to be on antibiotics before you come in for a procedure, any kind of dental work. We talked about the metal detectors earlier. Yes, you can set off metal detectors, so make sure you get your card, carry your card with you at all times, and when you get to the detector, just show it to the security person, let them know. Exercise is not done just during therapy. In the middle of the night while you're here, or when you're at home, and you're bored and you want something to do, pull out your book and do your exercises, okay? You don't have to wait for a therapist to be there. We're going to show you how to do the exercises and how to do them properly. So do them when we're not around. The more you do, the better it is for you. Don't overdo. If you start to hurt from the exercises, back off. But do some exercises when we're not around. Exercise is not just done for 3 months. It's a lifelong commitment. To get the best results, you have to keep exercising, you have to keep moving. And again, watch your body weight. Eat healthy, maintain an ideal body weight. Other pearls of wisdom, scarring can last up to 3 to 4 months after surgery. So your home health therapist, your outpatient therapist, they're going to slowly teach you how to do scar massages to help break up any possible scar tissue underneath the incision. When they teach you that, make sure you do the scar massages at home. Again, 1 year to heal, 2 years of strengthening. You're going to feel pretty good. You're going to feel pretty good in about 4 to 6 weeks. But you're still in this healing phase. It's going to take time. Be patient with it, all right? Best outcomes is when you're disciplined. You got to be disciplined with what we teach you. You got to be disciplined with what your surgeon tells you to do. There's going to be days you just can't do it, don't want to do it. Follow our instructions and you'll get the best results. Okay? The surgeon will slowly tell you when to start adding activities. Your surgeon's actually going to be communicating with your outpatient therapist as you go through this process. They're going to send reports to your surgeon, let them know how you're doing, and they're going to be responding back. You'll be going to follow-up visits pretty frequently, and so your surgeon's going to say, okay, you can start doing these activities now. Now you can do these activities. Now you can do these. So your therapist is going to tell you, your surgeon is going to tell you, so the three of you are going to be working together as a team to increase your activity level. On the day of surgery, when you come in, you're going to check in at the front desk like you have in the past if you've ever been here. They're going to get you signed in. They're going to go through your quick registration. They're going to take you up to the second floor. Someone from the surgery team is going to come out and get you and your family. They'll take you to the pre-op room. Once you're in there, they're going to get you into a hospital gown, and they're going to start to hook you up on the IVs. They may ask family to step out during that portion, okay? Once they've got everything set, they've got your knee clean, everything ready to go, they'll let family come in and sit with you. Usually about 2 people that can come and sit with you. After that's all taken care of, they take you into they get you to go to the operating room. Family will step out. Family members can go off campus if they want to, or they can stay somewhere on campus. They can go to the gift shop, they can go to the cafeteria, they can hang out in the waiting area, whatever they need to do. They just need to make sure that they leave a cell phone number or some type of phone number with a surgery team so that the surgeon or the nurses can call them and let them know how you're doing. Once you're done with surgery, you'll go to recovery. From recovery, you'll go to the 3rd floor. Once they get ready to send you to the 3rd floor, your family member can go to the 3rd floor, whatever room they tell them to go to, and they can wait for you there. Okay, so they can sit in the room. We'll see them up on the floor. Hey, I'm here for so-and-so. They told me to go to room 360. We'll escort them to room 360, let them sit in there until you show up. In about an hour or 2 hours after you get to your room on the 3rd floor, you'll see either me or Patrick come in. Patrick's my other PT. We're going to start therapy within 1 to 2 hours after you get to the floor. Okay, so you will have had about 3 to 4 hours of recovery before we see you. We'll start your therapy that day. We'll get you up, we'll get you moving, and we'll get you taken care of. And then we'll get you on a routine starting from there. Okay? All right, in the front of the book is my office number. It's an 830-500-6127 phone number. If you have any questions before your surgery, please feel free to call that number. Please feel free to leave me a voicemail. I may not get to the voicemail quickly. It may be lunch towards the end of the day, but I will respond to you if you leave me a voicemail, okay? So it should be on the second page there towards the top. All right, so that number is 830-500-6127. That's my office number. All right, we look forward to seeing you in a week or two whenever you're scheduled for surgery. And like I said, we hope that you enjoy your stay here. Please let us know if there's anything we can do for you while you're here. All right? All right, y'all have a great day. Thank you very much.